like to welcome everyone here. I'm glad that you guys came out. This is a project that, I'd like to thank the West Athens Westmont Task Force for inviting me to come, and Vermont Village for actually hosting us today. This is Kidney Month, if you guys didn't know, and World Kidney Day, I think, was yesterday. So this is something that's near and dear to me because it affects so many people in our community. But at the same time, so many people in our community don't have the information to help themselves. And that's one of the things that we're trying to do with these projects. So this is the first in a series of at least 3 of these talks in the community. And it's really more of a conversation. So I'm gonna give some key slides here, some key points about the disease and how it affects every other condition that someone may have. And then I'm gonna open the floor up for questions so that you guys can really get questions answered that you need. That's really what I'm here for. One of the things I always tell my patients and my students is that the root word of doctor is docere, which means to teach. It has nothing to do with being a physician. So if your physician or we physicians are not educating you, then we are doing you a disservice, but we're not holding our own to the craft itself. So that's one of the reasons we decided to have these community conversations. So I'm gonna open it up. Health disparities is something that's near and dear to us as well. Now, health disparities is in all of these conditions that you see: chronic kidney disease, diabetes, heart disease, cancers, prostate cancer, breast cancer, colorectal cancer, lupus, HIV. All of those affect Black and brown communities more than any other communities in the nation. And so kidney disease actually modulates all of these conditions. So you can say it's kind of a root to every condition you see here. The socioeconomic disparity also is in the Black and brown community. So adverse living conditions, poverty, income inequality, lack of access to health care over here, lack of health insurance, the environmental toxins. One of the things that we used to say years and years and years ago is that if you wanted to find out where the waste dumps were in any community, any city around the country, you could go to a minority community and find such, or just outside of that, okay? So it's very important that you understand that the socioeconomic disparities and health disparities are one and the same. People try to fragment them and segment them into separate categories to try to attack them in a different way. But I submit that it's a vicious circle. If your health is bad, you tend to have socioeconomic problems. If your socioeconomic problems are bad, you tend to have health problems, okay? So it's all one combine, as we say. So this slide is extremely important in that it tells you or shows you the root here. When inequalities are high, you guys have this in your slide book, you can just take a look at it. When inequalities are high and community assets are low, health outcomes are at their worst. So down here we have, just what I put on the other slide, adverse living conditions, segregation, income inequality, occupational hazards, unemployment, poverty here. All of this leads to increases in stress, cardiovascular disease, obesity, depression, infant mortality goes up, violence in the community goes up, and substance abuse. And violence is a health problem. So when everything is good, you got quality schools, you got clean environment, you got quality housing, access to health care, access to healthy foods, notice the relative shrink in how these problems affect community. And that's what this slide is supposed to show. So it all goes together. It really all goes together. So we're going to talk a little bit about diabetes. It's a big burden on our communities. So the general term for diabetes is disorders characterized by frequent urination. So there's lots of stuff that could be considered diabetes. So when we say diabetes, we're really talking about diabetes mellitus, which is a chronic syndrome of impaired carbohydrate, protein, and fat metabolism due to impaired insulin secretion or utilization by the body. Okay? There are three main types of diabetes that I want you guys to think about. There are more than this, but we just want you guys to think about type 1, which is a total lack of insulin secretion. Diabetes type 2 is a decrease in insulin secretion, but the body doesn't utilize insulin that well. So therefore, sugar stays outside of the cells that the insulin is trying to get the cells to take up the sugar to use it as fuel. Gestational diabetes is that diabetes associated with pregnancy. So what are the symptoms? Obviously, frequent urination, thirst, hunger, fatigue, blurred vision, and peripheral neuropathy or pins and needles. But one thing I wanted to point out is that a lot of times people have zero symptoms. In medical school, we learned that when someone is diagnosed with type 2 diabetes, that means they've had diabetes for 10 years before that. Okay? They've had it for 10 years. So the numbers may not reflect it, but something has been happening biochemically in the body to say that we're destroying blood vessels, we're destroying, different muscle cells, this kind of thing. We're piling up on blood cells, making the blood sludge a little bit. So little things are happening for 10 years before that in type 2. So most people don't have symptoms of diabetes. They don't have anything. So it's very important that we be aware of what these symptoms are, yes, but also be aware when you go to your physicians, what you need to be thinking about, asking about, and talking about with your doc. So the diagnosis is a fasting blood sugar. A fast is usually 8 hours without eating, 126 or above. Okay, so if your blood sugar is 126 or above, that's the definition of diabetes. We don't do this one anymore, really. 2 hours after a sugar load, that means you stay in your doctor's office for about 4 hours or so. Nobody wants to do that anymore. So if your blood sugar goes up to over 200 after we've given you a gram of sugar, then that is also the definition of diabetes. But the newer one that everybody talks about is the hemoglobin A1C. The hemoglobin A1C is a 3-month average of what your blood sugars have been, and it comes in percentages, okay? So above 6.5% is diabetes, okay? It is diabetes. Normal is 5.7%. So, or less, 5.7% or less. So what happens between 5.7 and 6.5? That's prediabetes. Now, some folks like me, I divide that even further into what we call impaired glucose tolerance or prediabetes. But really, I want you guys to think of between 5.7 and 6.5 as prediabetes, meaning I better do something, okay? So I don't like when patients are told, oh, you're all right. I want you guys to know these numbers so you can fire back, well, what's all right? Tell me the number. And you act very scientific when you're asking. I need to know my numbers, doc. Okay? So hypertension, this is another burden on our community. Complications related to hypertension in African American patients. Compared with the general population, there's a higher rate of hypertension, about 40%. Heart disease mortality, 50%. Obesity, 70%. Stroke mortality, meaning we die from strokes more than everybody else. Not that we have strokes more than everybody else, but that's true too, but it's not to this degree. We die from strokes more than everybody else at 80%. We have 100% more diabetes in our community than other communities. And we have 320% more kidney failure That's what ESRD is kidney failure. 320% more than white populations. So these diseases become extremely important in African American population. So what are the characteristics of hypertension in our population? Now, we have a greater severity, premature onset, meaning younger folks in our community get high blood pressure. Target organ injury means everywhere your blood flows to an organ, that organ gets damaged somewhat, okay? I'm a kidney doctor, so I look at the kidney quite often for this, but the pancreas gets lack of blood flow. The liver gets lack of blood flow. So all of these conditions, bones get lack of blood flow. So all of these conditions that we tend to think are separate and apart from what happens at the kidney or what happens with blood pressure are fallacies. Everything relates together. We are built to be a well-oiled machine at every cellular level. So impaired kidney function, as I said, is my main drag. So the target blood pressure should be 130 over 85 or less. I say 130 over 80 because that 5 throws people off. So if you guys remember 130 over 80, that's great, okay? So 130 over 80 or less is where your blood pressure should be. Don't let anybody tell you 140 over 80 is okay. It's not, okay? You need to be getting it down. Now, that doesn't mean that from time to time, because the body is dynamic. So your blood pressure is going to fluctuate. Your blood sugar is going to fluctuate. Everything's going to fluctuate. You're not a car, which means if the oil's low, the oil's low, period. In the body, there are systems that try to correct an imbalance. So there's an ebb and flow to what it is you do, or what it is happening in your body biochemically and physiologically, okay? But remember 130 over 80. And hopefully I have that slide here. Yes, okay? So cardiovascular mortality, heart attack, congestive heart failure, stroke. Some people lump kidney disease in there. Notice here that the number is 115 over 75 that they considered normal back then, or a risk of 1, no risk at all. 115 over 75. When you go 20 points on the top and 10 points on the bottom, your risk of developing one of these cardiovascular events goes up 2 times. So that number is still 135 over 85. So that's why I hate when doctors are telling our folks, or anybody for that matter, 140 over 80 is great. 140 over 90, oh, you're okay. No, you're not. No, you're not. If you go up to 155 over 95, your risk goes up 4 times of a heart attack or stroke. So the lower your blood pressure, and we've known this for a long time. This study came from 2002? Yeah, 2002, sorry. And we've known this for a very long time. But something I want you guys to know about where we get these blood pressure targets, okay? And I was in the School of Public Health, so we used to have all this literature that we reviewed, this, that, and the other. But there's a committee of people that get together, look at all of these studies, and decide what's good based on the studies. And so that number has been creeping up because there's also a financial thing to this, and that is the better controlled you have your patient population, the more cash you tend to get. So we've raised those levels, not thinking about the science. I go ballistic when I think of blood tests and what your hemoglobin or your blood count should be based on some other things, okay? But just so you know, there's a committee that gets together that's supposed to look at the science and say, hey, the science really is pointing us in this direction, this, that, and the other. Well, we had science from 2002 back 50, 60 years that said that 120 over 80 or less is good. And now all of a sudden that changed. But in the renal literature, in the kidney literature, 130 over 80 was good, okay? For most populations, not for every population. For some populations it had to be lower. I just want you to know this slide right here. Because now remember, slides before, heart disease, stroke, all of that was already higher in the Black and brown community. This is why, all right? I could go into some history about it, but we're gonna talk about that later on, I'm sure. This is just a combination of trials, and I really wanted to point out the numbers of medications, because a lot of people get upset when doctors are adding medications to them. This doctor's just pushing meds. Well, the actual literature tells us that between 3 and 4 medicines is what gets people controlled, okay? And it's better to do it that way, because I would much rather put somebody on a low dose of 2 medications than a high dose of 1 medication, because the side effect profile is terrible in some of these drugs when you get to higher and higher doses. So don't be too quick to say that the doctor's just putting me on medications, okay? All right. Now, chronic kidney disease. This is another one of those disparities, right? So chronic kidney disease refers to irreversible decrease in kidney function. Irreversible, okay? So, and that irreversible is not absolute, by the way, okay? We can talk about some naturopathic stuff and all of that later on, but it's not absolute. But the reason I mention this to you is that sometimes you'll go into an office and your kidney function will be down. And the doctor will say, you have chronic kidney disease stage 3, right? And I'm gonna teach you about the stages of kidney disease in the next bullet. But that's not always the case, because we've had to measure your kidney function at least 3 times, 2 to 3 times, over a span of 3 months to say that it's decreased and stable at that level, which means it's chronic, okay? So we have 5 different stages of kidney disease, and here they are right here. Notice this GFR number that you guys have in your handout. Just remember that GFR number is function. So above 90 is what's considered normal. But if you have above 90 and you have a little bit of protein in the urine, or a little bit of blood in the urine microscopically, or you have 1 kidney, or you have some other anatomic problem, we consider you stage 1, okay? We consider you stage 1. Now, there's stage 2, stage 3, stage 4, and stage 5. The reason this is important is that a lot of times the labs will not report out that you have any kidney problem until you get below 60. So you're already in stage 3. Guess what else? More people die of cardiovascular complications in stage 3 than any other stage of kidney disease. So that's absolute numbers of people. That's not percentages, okay? So percentages is down in stage 5. But I often tell my stage 5 patients, you are blessed to have stage 5, because most people don't make it through stage 3, okay? That's why you guys need to know these numbers. So when you have that, there are things that you can do to prevent your own demise, but to prevent a decline in your health, period, okay? So you may not be able to see this slide up here, but 35% of all dialysis patients are Black. 30% are Latin, okay? Black people make up only 13% of the population. And depending on what number you're looking at, but on average, it's 13% of the population. Some people say it's 14.5. I think it's around 13 still. All right, there's more money spent on African Americans in kidney disease than any other population. We don't have the data from COVID in our data that we've collected now. It's starting to trickle in now, okay? So with COVID, I think everybody knows that it hit the Black and Latin community hardest in terms of deaths and in terms of hospitalizations. So this data is gonna show, and I took care of people in the hospital with COVID. They call the kidney doctor because COVID definitely affected kidneys. And so there are people walking around who had COVID who now have chronic kidney disease because of COVID that's not even figured into the data yet. Okay? So it's a lot more. So there's a big push right now to decrease the cost of taking care of kidney disease. And it pains me sometimes because, you know, the media and the literature tends to talk about this very generally, but then they don't go back and figure in, we're spending more on African Americans in kidney disease, but now we're trying to cut kidney disease care because we need to lower the cost. So what is that doing to an already socioeconomic burdened, an already healthcare burdened community? It's basically lighting a match, you know? It's hastening decline of health, decline of socioeconomics in the Black and brown community. And it's something that we have to look at and put all of this literature together, not just leave it in silos. And that's what I'm a big proponent of. So by the numbers, I want to teach you what you need to know. I need you guys to keep this slide, these slides here. This particular slide here is what I want you to know and have. You can put it in your purse, put it in your wallet some kind of way, and, you know, there you go, put it in your phone. We're in technological age, that's right. See, I'm going back to the 90s where we didn't have them. So blood pressure, again, should be 130/80 or less. The average heart rate ranges from 60 to 100, but I want you guys to remember 60 to 80. That's where you really need to be, because higher heart rates actually lead to congestive heart failure as well. Higher heart rates for too long lead to congestive heart failure, okay? Diabetes, your fasting blood sugar, remember 126? Diabetes, remember your 3-month average, 6.5. You wanna be less than 6.5, you really wanna be 5.7, okay? So abnormal kidney function is a GFR less than 90. Don't let the lab tell you it's less than 60. It's less than 90, okay? Your urine should not have protein or microscopic blood in it. Should not. So you need to know on your urinalysis, if there's a little bit, if it says trace, you need to be like, hey, wait, doc, what's that mean? Okay? Trace blood. And most primary care doctors, not because they aren't smart people, they just don't know, they will say, oh, that's nothing. But it comes up again and again and again. You need to go see a nephrologist because you have stage 1 kidney disease. If your GFR, your function is normal, and you got microscopic blood, that's stage 1. We got problems, okay? So it's not a big problem, but we need to handle it now, right? So that slide is most important. So what should I eat? Now, I am a big proponent of foods high in antioxidants. Why? Because high blood pressure is an inflammatory condition. Diabetes is an inflammatory condition. Lupus is an inflammatory condition. Kidney disease is an inflammatory condition. Okay, so all of these diseases that we have, heart disease, stroke, all of that leads to an increase in inflammation, all right? And guess what? Stress of living leads to increased inflammation. So when people are talking about getting health plans to pay for massage therapy, acupuncture, that's legit. We need to make the health plans pay for that, because that absolutely is lowering inflammatory levels in people's bodies. It's not just, you know, somebody just getting relaxed, okay? That actual relaxation has a physiologic consequence, which is a positive consequence. So even prayer, okay? And I tell my patients this all the time. Are you a Christian? Are you Muslim? Whatever you are, sit and pray. Because that meditative force actually is causing a relaxation in all of your body. It's raising the relaxation hormones, which in turn causes dilatation of your blood vessels, lowering your blood pressure, minimizing inflammatory state. So, way back when, the Egyptians knew what it was, the Chinese knew what it was. You had to, get away from everybody and just chill, basically, okay? That has direct physiologic consequence. But these foods right here actually help that process along. It helps the process along. So you have blueberries, artichokes, walnuts, spinach, strawberries, green tea, kale. Anything on this list, which you guys have, raises your level of antioxidants. Because the way cells die are from oxidative stress, meaning more detergent is what oxidative stress is. So when you put detergent in your laundry and you see the bubbles come up, that is a reaction that is causing basically oxidation to get dirt off, all right? That same oxidation is deadly to a blood vessel, is deadly to an organ, but we have it in our bodies. It's deadly in too many amounts. I firmly believe that the human body was built to be in balance. And so when it's too low, it's bad. When it's too high, it's bad, all right? So the antioxidant properties that these things bring, not to mention their other properties, are very important for mitigating all those conditions that are higher in the Black and brown community, okay? So we need to grow our own stuff, right? So one thing I wanted to talk about as well is end-stage kidney disease. This is my last slide, and then I'm gonna open it up for everybody to ask me any question that you want. I'm more than happy to answer anything. It does not have to just be on kidney disease. It can be on anything you want, because if you have an infection in your toe, if I studied your urine enough, I could find it. The kidney handles everything. So I have to know everything as a good kidney doctor. But end-stage kidney disease, as I showed here, affects us 320% more than other populations. And then patients still pass away at about 4 to 5 years after being diagnosed with end-stage kidney disease. Well, why does that happen? I think it's because the system is jacked up. I think the system needs to have us as primary doctors of the dialysis patients, okay? That's me, the kidney doctor, being the primary doctor for a dialysis patient. So if you guys know any dialysis patients, you need to check on them, because 1 in 3 Black people know somebody on dialysis. 1 in 4 Latin people know somebody on dialysis. They need to check with us so that we can help these people live longer lives and live healthier lives based on our models of things. And that's what we're doing with K.CARE IPA, this company, okay? So we're here to educate the whole population on all of these different conditions that I mentioned up here. But we're also here to take care of those who missed the boat on getting preventative care early and now are suffering with conditions that their health can be mitigated. Everybody needs a wellness mindset. If you already have the disease, don't sleep on getting a wellness mindset, okay? You still can eat better. You still can exercise. You still can do all these other things that we tell everybody to do to prevent a condition. You can do that when you have the condition as well. So don't just give up. You can reach out to, particularly with kidney disease, with someone on dialysis, they can reach out to us and we will help them mitigate that. Okay, so without further ado, I'm gonna open up the questions. And Dorothy has the mic over there. If you guys just shout to Dorothy and ask any question you want. Thank you, by the way.
After a patient gets kidney transplant, should the kidney doctor be the primary caregiver, primary physician also?
Glad you said that. Yes, ma'am. Okay, and there's a reason for that. The way it's supposed to go is the transplant team will do the transplant. That's time 0, okay? The organ is functioning, it's doing well. So they ought to go to the office, to the transplant clinic, once a week for the first month, just to get checked out, get labs done, make sure everything's cool, this, that, and the other. After that month, they should go every 2 weeks for 2 months. After that, they should go once a month for 4 months. After that, they should go every quarter. And then they go back to their outpatient nephrologist in the community. But really, when they start going to quarterly visits with the transplant center, they need to also be having visits with us in the community, because we then are going to transition them to long-term transplant patients. The transplant medications, the function of the kidney, the increased risk of certain cancers, the increased risk of certain infections that are unique to a transplant population, primary care doctor don't know. They don't know. And again, they didn't study it. Not that they're not smart, that's not what I'm saying. I'm saying they didn't study it. But what winds up happening in managed care? That patient goes back to the primary doctor and they have to wait to get a consult with me. In between the time they could actually see me because of an authorization, it might be 3 months. But they're coming off transplant. Something that the primary care doctor doesn't know squat about, right? Yes, they know about diabetes, but do they know about diabetes and how you manage that with prednisone and mycophenolate mofetil? And no, they don't. They don't. Or tacrolimus, something like that. They don't understand that. They weren't trained to do that. So the system has it set up for these people not to do well. And for transplants to fail earlier in our community, when we do get a transplant, it fails earlier in our community, and then they try to chalk it up to, oh, well, Black people's immune system is too aggressive. So that's why their transplants fail. No, it's because the system puts them in a cycle that doesn't allow us to look at things precisely, right? And then on the back end, people go back and forth to the transplant center, all right? They just keep going to the transplant center every quarter for life, it seems, until the transplant center gets tired. But guess what? Those are the surgeons and nephrologists who take care of transplant immediately post-operative. So these long-term complications, they have read about, but they don't see. So the transplant center itself doesn't see the cancers popping up. It's us as outpatient docs that can say, hey, we need to screen you for that, we need to screen you for that. Now, the transplant center will see those weird infections that I'm telling you about. So that's why I'm a big proponent for a kidney doctor, anybody with end-stage kidney disease, whether they have dialysis or transplant, I need to be their primary, period. But yeah, so that's the answer. We need to be the primary, yes.
I have a mic.
Who? Oh.
We talk about cleaning the arteries. How do you do that? Is it just by eating the antioxidants that you showed, or is there another method that we should be achieving?
Well, the short answer is yes, the antioxidants are very important. But there are other natural things that have been found. One of them comes to mind, L-arginine, which is something you can buy online. But I'm just saying, L-arginine is the only substance that's been shown to take a plaque, meaning coronary artery plaque, a lipid plaque or a cholesterol plaque that we get in blood vessels. It's the only thing that's been shown to start taking it off.
Will you spell that?
Okay, L-arginine. Okay? And if you're going to get it online, there are 2 companies that have a good delivery system that I like. One is called L-arginine Pro, and then the other one is called proarginine. It's two different companies. The reason the delivery system is important is because the other delivery systems for the L-arginine is good, but these other delivery systems actually raise acid in the bloodstream. They create a reaction to raise the acid in the bloodstream, whereas these other two are a combination of complex sugar, but the complex sugar undergoes a biochemical change that softens that acidity that comes. And that's why I like those two. I got no stock in either one of them. I should, but I don't. I'm kidding. Next question. Yes, sir.
Along with other questions, is it true that exercise, or specific exercise and diet can mitigate some of these issues?
Yes, sir. Absolutely. I'm glad you brought that up, because what exercise does is exercise, and I'm not going to get into the types of exercise because we're in church, but exercise will increase something called GABA-aminobutyric acid in the brain. It's a relaxation hormone. So you exercise. The minute you stop, GABA goes up. GABA is that relaxation that I was talking about that goes to each blood vessel to keep the blood vessel cleansed, not just flexible, but cleansed, because it sends out an antioxidant type signal. It's antioxidants plus other signaling that cells do after exercise to basically just sweep out the blood vessels all over the body. It just sweeps it out, because you've exercised. See, exercise liberates toxic chemicals that you need to get rid of. So all of these cellular mechanics respond to this, and the blood vessels start getting swept out. So exercise is very important to keeping all of that at bay. Absolutely right. Yes, ma'am.
Yes, I had a question about what you mentioned about the L-arginine.
Mm-hmm.
Is that why some people take statins?
No.
Oh, okay.
No, but L-arginine has been shown to lower cholesterol as well. L-arginine has also been shown to decrease blood sugars. L-arginine has also been shown for the blood vessel thing that I was talking about. It's also been shown to lower blood pressure. So there's something about the antioxidant effect of L-arginine that goes beyond just antioxidant effect, right? So the statins are very important because your liver produces cholesterol at night when you're sleeping, okay? So all the stuff you ate during the day, your cholesterol gets produced at night. So the statins stop that process from going on so vigorously at night. Because if you've eaten junk, the junk is just sitting around waiting for the liver to do something. And then the liver does it, boy, I'm telling you, the liver will do it. So the statin cuts that process. It also eliminates some other coenzymes like CoQ10, I'm sure you guys have heard of on the television. But the statins are very important to stop that process, whereas the L-arginine is the after that process has happened, we now need to help it out. And it stops that extra cholesterol from being deposited on those plaques, but it doesn't stop the cholesterol production, right?
Okay, so, but it doesn't, some deleterious effects
Oh, absolutely.
of statins.
Absolutely. Absolutely, without question. So the main thing I worry about with statins is muscle breakdown, because it will destroy cells in people who are sensitive to it, and you'll get something called rhabdomyolysis. And rhabdomyolysis actually is muscle cells dying, and then those muscle cells, when they die, they get in the bloodstream, they go all the way to the kidney, and they shut the kidney down. And so I've put people on dialysis from rhabdomyolysis. However, I will tell you, as a former and current drug researcher, everything is in balance. It has to be in balance. So people get afraid of Western medicine, and then they'll run out to naturopathic medicine, Ayurvedic medicine. My friends from Nigeria, we call it bush medicine. But all these medicines are complementary. Some stuff will work. Western stuff will work for some people, whereas it won't work for other people. It's the absolute truth that we have got to look at other things, like acupuncture, they didn't think worked at all. They wouldn't pay for acupuncture. We were laughed at in the 90s when I was training when I wanted to get somebody acupuncture when I was in the clinic. They laughed at me back then. But now we got study after study after study after study on acupuncture that shows that it's actually a physiologically good thing. So my point is, don't be afraid of medicines, but also pay attention, because 10 milligrams of a statin for you may be enough, whereas it might not be enough for somebody else. Somebody else may get 80 milligrams. You know what I mean? Or you may have a reaction to one statin and we try to put you on another statin. Because in my experience, one statin the patient may have an effect to. If I could put them on another statin, they may not have that effect, that statin. But if they have an effect, if the patient has a deleterious effect with both statins, I know it's a class effect and I'll never put you on another statin. Because you got to remember, the way we study things is that there is a receptor in the body to accept something, and then there is the molecule. So whenever you have, let's take statins for example, whenever you have atorvastatin and simvastatin, the statin part of the molecule is the same, but the other part of the molecule makes the simva or the atorva part. Does that make sense?
My neighbor is a chemist and he tells me all of these.
Okay.
I mean, but that's why I recognize what you're saying.
Mm-hmm.
But I have one more question.
Yes, ma'am.
One more question. Only one more question, I promise. You mentioned something about a balance.
Correct.
The body has to have a balance.
Correct.
You know, they're pushing the alkaline water and the, just the pH, keeping the pH in the water and what to drink and what not to drink. So I was just wondering about what is your take on buying whatever the percentage of alkaline?
9.5 or whatever, yeah.
Yeah, whatever they put.
So at first I had to think about this biochemically. And biochemically, the body don't cur. The body don't cur. So that's biochemically, okay? But when you think about it, because what happens at the kidney level is the kidney takes any fluid that you get and puts it back at a pH of 7.4. Or, 7.3, 7.5, 7.4, okay? So if someone has gut issues with H. pylori, for instance. H. pylori is a bacteria that only grows in the stomach. It causes stomach ulcers, it causes gastritis, it causes reflux, it causes all this stuff, right? So reflux disease is acid refluxing up into the esophagus. Gastritis is a breakdown in gastric tissue, stomach tissue, that the acid that itself is producing now affects that area that has been eroded. One of the things I surmised is that alkaline water could be beneficial in those situations because now that detrimental acid, the pH is raised just a little bit. Now the pH of the stomach is 3, which is highly acidic. It's the most acidic place in our body. And I told you blood pH is 7.4. But if we can raise that pH, now this is just me theoretically talking from a biochemical standpoint in the stomach, if we can theoretically raise that pH a little bit, it will mitigate the problem, number one, because of the acid itself, but also H. pylori, that bacteria loves acid. So it will stop, again, theoretically, it will stop H. pylori from wanting to reproduce in the stomach to cause these ulcers and this kind of thing. Not only that, that alkaline water then passes into the duodenum, right? And so I can see it flushing the duodenum a lot better that's used to receiving highly acidic stuff, particularly when we've eaten processed crap, right? Because it's in the duodenum or duodenum, some people pronounce it. It's in there that pancreatic juice, bile juice, all of that is coming in, and that stuff is designed to raise the pH a little bit as we continue to digest. So alkaline water definitely can help in those situations. And over time, that same alkaline water will get absorbed over time, right? And so the kidney then has less work to do raising the pH. So just teleologically, if you don't have to expend as much energy on that digestive process, then technically you should feel a little bit better because not all of your energy is going to do that stuff with alkaline water. So the jury is still out with me, but I always try to think about things in terms of what they actually mean from a body standpoint, from a physiologic standpoint. So I see how alkaline water can be valuable, but the way they talk about how alkaline water can be valuable, they go over the top a little bit. I'm sorry, they go over the top a little bit. Okay? Yeah, exactly, balance. Anybody else? Okay.
What does it mean when you have a tumor, if a family member, can you have a kidney and a half, first of all?
Can you have a kidney
And a half?
and a half of a kidney?
Yeah.
Absolutely.
Okay, now, he has, a family member has a kidney and a half from a tumor, and the tumor was cancerous. So how would you, where does the cancerous tumor come from and how can you prevent?
All right. So one of the things that happens is that what the tumor that you're describing is something we call renal cell carcinoma, okay? And I was about to say the beauty of it, but that's me being a scientist. Renal cell carcinoma can grow huge before it metastasizes. And so what it does is it will crush whatever, because your kidney is in lobes, right? So it will crush the lobe of whatever kidney it is and take over. But it won't metastasize to the rest of the body. It'll just be there, right? So that can take out the function of the top of the kidney and leave the bottom half of the kidney. So that's number one. The way this cancer works is similar to other cancers, and I always explain cancer this way to lay people, okay? Is that there's a two-hit hypothesis for most cancers. That is, your body is set up for cancer by genetics, by you smoking all the time, by whatever. It's set up for cancer. And then there is an environmental carcinogen or the second hit, the second punch to that tissue that will then cause the cancer. Like if you look at bladder cancer, aniline dyes do that. You know, that's just somebody working in a factory. You know what I mean? But the aniline dye affects kidney tissue as well. So that's how cancer, that renal cell cancer develops. But the good thing for your loved one is that that cancer can grow to a huge size without metastasizing. And yes, we got to cut it out. But when we cut it out, it's cured. When we cut it out, it's cured. So make sure they get to the doctor and to the urologist specifically to get that ready to be removed. Because once it hits the edge of the kidney and goes, there's a capsule that's around the kidney that the kidney is encapsulated in. If it bursts through that capsule, then the cancer cells go everywhere. And that's death. I have known nobody to come back from metastatic renal cell cancer. Okay? So that's why I say renal cell cancer, it's fortunate because we got plenty of time to discover it, plenty of time to treat it. Okay? All right. Anybody else? Oh. Okay.
Thank you again, Dr. Anthony. My question is, what are those two companies that you recommend for the purchase of the that supplement?
I forget the name of the companies, honestly.
Okay.
I forget the name, and I do it on purpose so I don't buy stock.
But are you able to email it to us later?
Yeah, I can do that. If you just look up Pro-Arginine, I think, I'm not going to even guess. I don't know.
I looked up
L-Arginine Pro is one of the companies. Right, that one.
So
I don't know.
a few, but because while.
That's all right.
I'll ask you offline what that looks like.
Okay.
Because this is impacting myself in real time.
Yeah.
But it's also impacting like my loved ones.
Yes.
So I'm hoping that by me modeling in real time what these different things will do and how to be preventative,
Yes.
that will probably motivate them to get on board.
Cool.
Because they keep asking, how can we support you? Come on, let's all eat this salad together.
Exactly. That's beautiful. That's how you do it. That's how you do it. Okay. I think we had another couple questions here.
In August, I was diagnosed with prostate cancer, and it spread into my lymph nodes, and it blocked the function of my kidneys. And they put tubes in my back so my kidneys would function. Once they put the tubes in, my kidneys started functioning normal.
That's right.
And the prostate had spread it. It spread it from my into my hip and my lower back. But I've been making good progress.
Yes, sir.
It's been since August. My numbers are down to 5 now.
All right.
So I just wanted to know what you thought about the procedure that I went through on that.
Well, you had something called obstructive nephropathy, or a blockage causing pressure going back up to the kidney, and it knocked the kidneys out. So we had to put tubes in the ureter to drain the urine out so it would relieve the pressure on the kidney. Now, you keep the faith with that prostate cancer, brother. All right? Because there is the oncologist. These brothers and sisters have found out some stuff with prostate cancer that I've seen metastatic prostate cancer be cured. You know, so don't you sweat for 2 seconds. You know, the man upstairs, we know exactly what to pray for, done. You know what I mean? So anyway, that's what we have to do in order to preserve kidney function. So there's pre-kidney disease, which is usually dehydration. Then there's disease that affects the kidney tissue directly. We call that intrinsic. And then there's post-kidney disease. Something obstructs and leads back, okay? So the fact that you had that happen, and it sounds like they got to it very quickly, okay? Because they got to it very quickly, your kidney should recover, okay? It may not recover all the way back to that 90, that normal, because quite frankly, that normal calculation is based on someone's age in the first place. So someone's age may cause them to calculate into the stage 2 range or the stage 3 range even. And we freak out and say, oh, you got chronic kidney disease, blah, blah, blah. Yeah, we got to call it that. But for this patient, it's kind of their norm. You know what I mean? So we just need to watch your kidney function every single time we're checking laboratories, every single time you're doing a urinalysis. We need to follow that like a hawk because it should recover very well.
I think it has. They removed one of the tubes Monday.
That means you're right on the money.
Right.
That means you're right on the money, brother. Yes, sir. Yes, sir. I love it.
Alice, I got 2 questions. The first one is, L-arginine, is that a pill or how often do you take it?
It's a powder.
It's a powder.
Okay. It comes in a little container, and it's a small scoop that you use. Now, the bottle the canister is going to tell you, use this twice a day. Man, they trying to make money. Use it once a day, okay, and you're fine, okay? Now, I also will say a baby aspirin is also protective. So don't sleep on the baby aspirin pulling for the L-arginine, okay? They help together. So everybody should be on a baby aspirin to be cardioprotective, and it protects you against stroke. We got mad data on that actually shows a significant decrease in stroke and heart attack. And that's something I think our community doesn't do either. We don't adhere to that. We don't take the baby aspirin, okay? So, yeah. Your second one?
The second one is, do you treat the mind when you have patients that come in for different ailments? Let's say like a kidney plant transplant. Maybe their diet might not change after they've had the transplant.
Oh, they won't get the transplant.
But after they have it, okay, they go back to what they used to do.
Right.
So I'm trying to say that the mind treated as well.
Absolutely. With transplant, you have to go through several different types of evaluation. So one of the evaluations is a mental status exam. Okay, so you've got to be able to pass the mental status exam, but also look at your lifestyle. We look at all of your socioeconomic factors. One of the reasons I think we don't get as many transplants as others is because those socioeconomic factors mess that up. Okay, so for instance, a person who lives in a nursing home cannot qualify for a transplant. Okay. If we come to your home and see that you have a one-room home with 50 cats, you can't get a transplant. Okay. So those socioeconomic factors, but also the mental factors. Have you been adherent to your dialysis schedule? How do you eat? How are you going to take these medications that we give you? Because transplant medications can be deep. You miss one dose and your kidney can reject. You know what I mean? So we're very careful about who we put on transplant. That's another shameless plug, is that one of the things that we do as primary doctors is our patients on dialysis, we recognize depression quickly, because depression is much higher in the dialysis population than even certain cancer populations. So when someone comes into dialysis, that's why when you come to my dialysis unit, you know, I always have my staff kind of being jovial, relaxed, not we're here to do your dialysis, boom, boom. No. Be jovial, be relaxed, because then you pick up on who's depressed, right? And you pick up on who's depressed, and you can treat that before they get to transplant. Because if they're depressed and you submit a transplant referral, they will get denied because they're depressed and not treated. Now, if they're depressed and treated, all's fair. But if they are simply depressed and haven't been treated, they won't list you for transplant until you get it treated. So what we do is part of our programming, we do that right away. We figure out what's your mental status looking like.
I know I said it too, but it has nothing to do with diabetes.
Okay.
I want to know if you're familiar with the gene therapy for sickle cell patients. My son is in the process of trying to be matched with one of his siblings. And City of Hope, is going to do it.
Right.
They are testing it now.
I love the idea of gene therapy. And it really stems from stem cell therapy and stem cell research, okay? Because I was kind of a cool nerd in medical school, so I love this kind of stuff right here, because you could actually see from bone marrow stem cells. There's something called a pluripotent stem cell, and then there is a precursor to a tissue stem cell, right? So the pluripotent stem cell can grow into any cell in the body. And if we take those cells one step removed from, we take another stem cell that is supposed to be a blood cell, and we can grow that blood cell without the valine to leucine change on sickle cell, that's the bomb. All right, and so I wholeheartedly want you to go forward with that, because that is growing blood cells is the simplest thing a stem cell can do, if you look at the biochemistry of a stem cell. So go for that. I believe in that 100%, because we're trying to grow kidneys right now from a pluripotent stem cell. Yeah. Yes, ma'am.
I have one question and a statement. Well, first of all, Dr. Anthony, I have to thank you for the slide, ask questions about your numbers,
Yes.
because this could save your life.
Yes, ma'am.
And that's one of the things that when I said put it on your phone, when you are communicating with your doctor, many people think that whatever their doctor says is gold,
Right.
right?
Yeah.
And if you've got an opportunity to communicate with them and ask them the questions as to why, it could potentially save your life. And if your doctor won't answer those questions for you, then that's not the doctor for you.
Time to bounce.
I mean, understand you can always change your primary care doctor.
That's correct.
That is so important. He's got to work with you. Now, my other question is, so I know you've referenced many times about the COVID stats not being factored into care. So we talk about health disparities, and 35% of African Americans have end-stage renal disease.
Well, it's of the dialysis population.
Of the dialysis.
35% are African American, yes.
So once these stats are factored in, then what are we looking at?
And forgive me for sighing. It's just as one of the few Black nephrologists in the world, it hurts because I know COVID affected us, and COVID is going to increase the numbers of patients with end-stage kidney disease over time. We've already grown crazy since 2010. We've more than doubled since then in terms of how many people are on dialysis. But also, African Americans carry a gene called APOL1 that we're just now, well, in the last several years, really getting a handle on. And just like sickle cell trait protects us from malaria, APOL1 protects us from African sleeping sickness or trypanosomiasis. It's a parasite that is in West Africa. Actually, I'm talking to y'all about how much history I love, but the Songhai region, you remember the Songhai dynasty? Anyway, never mind, let me stop. In the 1300s, the Songhai region was basically all of West Africa crossing over into East Africa. That was the Songhai dynasty, or dynasties, the Songhai region. So all that region, we come from there, from Ghana, from Nigeria, from Ivory Coast. We come from there. And all over there, everybody developed APOL1 because people were dying of African sleeping sickness. And so in his infinite wisdom, we mutated, if you will, to have this particular protective gene. The reason I mention that is because COVID is inflammatory and we have all these other inflammatory conditions. Those people who have COVID, who have chronic kidney disease now are at higher risk of progressing to end-stage renal disease. And if they have APOL1 gene gets turned on from inflammation. So they're at much higher risk of progressing to end-stage renal disease very quickly, right? So when someone has this APOL1 gene, we need to be super aggressive with diabetes, super aggressive with hypertension, super aggressive with a lupus or something else that someone may have that's inflammatory. But we don't do that. And the kidney doctor we're down the pipeline. We're down the pipeline. So we're trying to get the word out about APOL1 to our primary care doctor colleagues, but it's going to grow big time. And we have to have a way to care for it. Right now, the only way to care for it is to get prepared to cut dollars from it. They've already done that. they instituted, you guys don't know this, but they instituted what's called a medication bundle for dialysis patients. In that medication bundle, they chose the cheapest medications to put in the bundle that the payers would pay for. Are they the most effective medicines? Absolutely not. So they're putting calcium acetate, okay? Let me just back up just for 1 second. When you're on dialysis, your phosphorus goes way up because your kidney can't get rid of it. And so we give people medicines who are on dialysis to lower their phosphorus. So every time you eat something, your food has phosphorus in it. So we have to have people eat one of these pills as they're eating 3 times a day at least. And if you have a snack, you eat more. Because it prevents your phosphorus from going high, it prevents your bones from getting brittle and you breaking a bone and checking out of here because you broke a bone, right? Calcium acetate, or calcium itself, has been shown in dialysis patients to get up on their coronary arteries and make the coronaries harden. So more heart attacks happen in those people, more strokes happen in those people. Why are we giving them that medication? Because it's cheap. I hate that. I hate that. So the medicines that have been shown to be beneficial and not do that calcium thing and actually prolong life, yeah, they cost more. So the pharmaceutical company needs to have a heart, number one. But number two, the payers have to say, you know what, screw this, we got to take care of these folks, period. Because the problem is that they set up the social part of the system. And I'm about to get on my soapbox, but I'm trying not to preach on this one. Okay, so they set up the social system such that if a dialysis patient who's already financially strapped starts job training, some of their benefit gets cut. It gets cut. But they don't realize that if a dialysis patient is doing well on dialysis, we get them the right medications, and they want to go be productive in society, they are getting tax revenue from them being productive in society. So why are we not pushing job training in our dialysis patients who simply want to be a part of society? They go to dialysis, they go home. Somebody might visit them, but they go to dialysis, they go home. They go to dialysis, they go home. They go to dialysis, they go home. They might go out shopping for a little bit, but they get tired, so they come home. We need to treat them the best way we can so that they can mingle with us and not be ashamed of it. They can go out to dinner with us because guess what? We've given them the right food to do so. We need to do all these things for this patient population because I'm telling you, it costs a lot to do dialysis. It costs a lot. So yes, we need to prevent. But what I'm telling you is that because of what COVID did, we got a lot more coming soon, right? Within the next 3 years, it's going to rise, rise, rise. And I'm just fearful that our politicians don't fully understand how care is delivered. And then doctors are like, you know, people used to hate me in medical school because I was always saying, well, why don't we tell them we need this? And why don't we tell? But I came from a public health background before I went to medical school. So I'm always looking at what affects the public. How does this affect the public, right? And then I go into my one-on-one doctor with you. Because like I look at you and I say, okay, what patient population does she come from? Right? That's the first thing I think about when you walk in because I'm a public health, I'm an epidemiologist before I became a doctor. So I look at your demographic before I start treating you. And then as I talk to you, I'm not biased because I see the demographic. That doesn't mean I have to treat according to that, according to generalities anymore. I see your demographic, so I need to treat you based on you, not based on everybody else, right? We don't do that. We don't do that as docs. We get literature that tells us that, you know, calcium channel blockers are good for black people. And so any black person walks in, here you go, here you go, here you go, here you go, here you go. And I'm like, wait a minute. You know, this is a black Jamaican. This ain't a black Iowan. You know, so my point is I'm fearful that we're going to lose our politicians to simply looking at cost and lose our payers to simply looking at cost when they don't know what happens at the dialysis chair with the doctor. They don't know that the doctor has the skill set that they're trying to give to a case manager sitting in a room at a health plan. You see what I'm saying? So I want to prevent, but we're not going to be able to prevent everybody. That's the reason we're doing this. That's the reason I want to come out here and talk to everybody. Because if y'all know and you see stuff coming down the pipeline for political, you know, we got to vote on, you know how we vote on everything here. It's raining outside. Should we put a shelter up? I mean, we got to take a vote. No. But that's what I fear, is that the politicians are going to get their mitts into dialysis patients cost 7% of the total Medicare budget, total Medicare, not just the clinical budget, but the total Medicare budget, and they make up less than 1% of the Medicare population. That's huge. So I hope we can get it right. I want to teach y'all everything I can so you can protect yourselves, but also so you can be a voice, when certain things come down the pipe. I'm sorry. Go ahead.
My thing is, what happens, I think, with the community and the Black community and other communities too, is that people don't understand when they purchase their insurance. They don't understand what their insurance can do for them.
That's right. That's right.
It limits, when they need a specialist, their insurance is saying, most of the insurance is saying, oh, you have to get approval.
Right.
Sometimes that approval is taking 4 months. A lot of us are older in here, and I always would tell people, 2 things is, make sure you got your food, make sure you got insurance, because that's the only place we're going.
That's right. That's right.
So I know to do some of the insurances is a little high, but it's worth it because I pay for insurance with the Medicare. So yes, I have UCLA doctors, I got you, and when I want you, I just call you up.
That's right.
I don't have to wait for approval.
That's right.
That approval can cost me my health.
Well, can I chime in right there too? Yeah. One of the reasons that I teach this is so people know the importance of it. So, 4 words to your doctor. Can you expedite that? I'm medical director of an MSO. I have been for a long time now. MSO is basically health plan type stuff. And one of the things that I've noticed, or that I know, is that when we expedite an authorization, by law, they're required to give us an answer in 3 days. And if they don't give us an answer in 3 days, the ombudsman could be hearing something. What we don't do is we don't say, hey, this was supposed to happen in 3 days. Why didn't it happen in 3 days? And we yell at the doctor. We get to the doctor's office and say, y'all should have done da-da-da-da-da. But because we don't understand the system, not understanding that we're the doctor, we're waiting on it too. We're waiting on it too. So my staff can pick up the phone and call and see where it is and this, that, and the other. But it's somebody on the other line. There's something called Milliman criteria or interqual criteria that someone who doesn't even have medical training sometimes looks at and says, the note doesn't fit that criteria exactly, so we're going to deny that. Not a clinician at all.
And when they deny it, even when you go to your lab, there's certain labs that you will order, and you will get a bill from the lab coming, because when you go,
right.
Sometimes they ask you to sign.
That's right.
Because your insurance probably won't pay for this. When they deny you, they're gonna send you a bill.
Yep.
Then sometimes these bills are $200 and $300. No.
Right.
If your Medicare denied that bill, send a thing into Medicare and says, no, I refuse to pay for this because I have this and this is why I want it.
Right.
Once you deny it, 99% Medicare is gonna pay for it.
Right. Right. Exactly. But so we got to know that's the socioeconomic part of this that I'm talking about. That's why I say it's not just medicine that I'm out here preaching. You know, it's the preventative part, yes. It's what we can do to treat ourselves, yes. But it's also mixing these kinds of things in. Now, you know, full disclosure, Ms. Watkins is a nurse. She knows this. Okay, she knows this stuff. Okay, so it's important that we all understand both sides of the coin, right? That's how we uplift our communities is by understanding both sides of the coin. And the more of us that can understand both sides of the coin, we won't get these things that we have to vote on for our community or allocated to our community. We can rebel rouse and say, wait, hold up. We don't have this, and this in our hood. I'm sorry, in our community. In our community. You know what I mean? It's imperative that the Black and brown communities get more active when it comes to healthcare infrastructure in our communities. Because guess what? I bet you DaVita's there. DaVita's a dialysis company. I bet you it's there. I bet you Fresenius is there. But do you have a center where you can just simply go ask questions? You know, years ago, I wanted to set up a health ministry at different churches around the city, okay? And have smaller churches feed into that church for information only, so that all of our communities had health information. Because where did we get it from? My dad was the first man to vote in North Mississippi. So I come from a long line of rebel rousers, you could say. But I don't have guns to my head like they did. So kudos to them. But it's the truth. He used to teach me all the time that everything came through the church. Everything we did came through the church. And we would close the door, hoop and holler, fight, fuss, whatever. But when we walked out the door, even if I didn't like the decision, I'm going with it. Because that's what our community said. And that's what we need to get back to. We can come back and debate with our community, but what do? I'm preaching again, sorry. We say, I ain't fooling with him. I ain't fooling with him. I ain't fooling with them. But what we have to do is understand that there's a process to how we have to get things done. And it hurts me when I, as a Black nephrologist, cannot get on the rolls of certain health plans. I can't be a provider for certain health plans because they tell me, oh, we already have enough nephrologists. I'm like, how many Black nephrologists you got? Oh, none, but we have enough nephrologists. I'm like, okay, all right. And where are you located? Oh, well, we have 300,000 African Americans on our rolls. Oh, and you don't have Black nephrologists? And, you know, last I checked, 18.8% of our people have chronic kidney disease? Let's see how this is gonna work. So the point is that there are things that we have to do. We have to educate ourselves about this stuff. We have to educate ourselves about this stuff. But we also have to recognize that this stuff is only a part of our solution. But the more you guys understand about blood pressure and diabetes and all of that kind of stuff, you'll be able to look around and say, we don't have these kind of resources, kind of access to stuff that we need, you know? I mean, one of the things that diabetes causes is peripheral vascular disease of people's feet. How many Black podiatrists we got? How many people are doing preventative vascular stuff in our community? Very few. It's all at the hospital. All at the hospital. Or you got to travel to Whittier to get it. You see what I'm saying? It's things like that that are meaningful to me. Yes, I love treating each and every one of y'all. I love teaching this stuff. But there's something beyond what I do. There's something beyond what we do. There has got to be an understanding of this stuff so that you can understand how the socioeconomics impacts it. And it just keeps cycling. It just keeps cycling. You know, there's a guy who was kind of a pseudo mentor named Dr. Smith down in Mississippi. He, starting in the 60s, he was the doctor basically for Jackson. And he kind of did this. He went to Tougaloo and Tougaloo's a college in Mississippi, if y'all don't know. He went to Tougaloo, he went to Jackson State, he went to these different places around Alcorn, Mississippi Valley. He went to all of these colleges recruiting for doctors, you know? And this is what we need to be doing. But that's the social side. That's the provider side. Do you know how few providers, Black and Latin, are going into medicine now? Very few. Very few. So we got work to do as a community, because if the community says, hey, we need you, that bucks a young guy up. Oh man, my community needs me. I gotta do something. You know? So I'm sorry to get on my soapbox, but really, you know, thank you to the West Athens Westmont Task Force. Oh, you got another question over here? I'm sorry. Three-part. Oh, here we go.
Diabetes, I've heard it's reversible. Is that a fact?
It depends on how far along it is.
And if it is the number still 6.0? And then how long would they have to maintain to be considered reversed?
The number is 6.5.
6.5.
Okay. And reverse means we can look at that. I don't like the term reverse. And let me tell you why. Because as a clinician, if you had it once, you're at risk to get it again. So I like to say in remission, just like with cancer. I'll say in remission, okay? But that's very possible. That's very possible. I've seen it.
Okay, and then because if he gets below the number, and then they keep telling my brother, well, the doctor keeps saying that I still have it.
You do. You're in remission.
So she's actually right when he says it.
Well, in a clinician's book, yes. Okay. Because what we don't ever want to do is lose sight of someone who had it, who we know if they had it, they're at risk to get it again. It's like breast cancer, okay? Your breast cancer could be cured, but as doctors, we say in remission. Because we still gonna look later on to see if another lesion is there somewhere later down the line. You know what I mean? So it's, so the answer is yes, but with that caveat, that's it.
And you were saying something, when you mentioned the ABL1 gene, and you said something of the sickle cell anemia trait. Mm-hmm. And why is that so important?
Let me explain. Let me explain. So I want you to follow me on this because I'm teaching you some medicine right now. All right. So a certain type of Malaria falciparum is a certain type of little parasite. And it gets in the blood cell, right, and sets up shop and causes that blood cell to sickle. Okay? But it doesn't stay always. What it does is it can cause a gene change. Okay? Well, it causes them to sickle, and then the body does its thing and produces this different gene to make it sickle. Now, that gets passed along. All right? So if you have sickle cell trait, the Malarium falciparum can't get in the blood cell. It can't get inside the blood cell to cause full-blown malaria. But if the body's under stress, those cells will sickle, even if you have sickle cell trait. I have sickle cell trait. I can't go above 8,000 feet when I go skiing. Otherwise, I get sickness. My cells will sickle, and my stomach will hurt. I'll have I have full-blown sickle cell syndrome when I go above 8,000 feet. I went to Aspen and almost thought I was checking out because my chest was hurting the whole nine. I had to descend, right? So anyway, so that's that. Now with APOL1, it's a gene that we carry because trypanosomiasis is a parasite that also does damage. Okay, similar, not the same, but similar. Now, the APOL1 kind of sits in kidney tissue, all right? And so if that gene is turned on, right, through inflammation, it causes renal failure. But if the gene is turned on with an infection with the trypanosome, it kills the trypanosome, in essence. That's not exactly what it does, but in essence, I want you to think about it. It killed the trypanosome. So you don't develop the full-blown African sleeping sickness, all right? So you don't go into a coma and check out of here, basically. You might get a little sick, have some sniffles, but you don't get the encephalopathy, which is the swelling of the brain and all of that. You don't get all of that, all right? So it's a protectant to something that has been in our environment, which is why I mentioned the Songhai dynasties. The Songhai Empire covered all of that. And that's where our gene pool comes from, right? So our brothers and sisters in Mexico, their gene pool comes from the same place. We're all one, is what I'm getting at. When you look at black and brown people, we are so similar in terms of our health. It's ridiculous. Even biochemically, physically, very similar. So a lot of our brothers and sisters from Central America also have this gene. And so they develop the same thing. I've seen Latin people with sickle cell anemia. We used to think, it's just a black disease. No, it's not. No, it's not. We've been everywhere. So it's important that we understand that. So that's how that works, all right? That's how it works. And 52% of us have a gene for this. 52% of African Americans have this gene. No. The APOL1, 52% of us have it. Now, it's a higher percentage, I think, for sickle cell genes. Okay, it's a much higher percentage. Okay, so anyhow, any other questions? Oh, you got another question.
Last thing I asked before that is, if just say I wanted to go and get a license to be a kidney doctor, and I'm African American, and there's not many of us. So if I was to get my license in California, how limited would I be to care with anyone else in the United States?
Okay, hold up. Now we're gonna back way up. Okay, so first, you have to go to college, 4 years of college. Then you have to go to 4 years of medical school. I did 2 years of grad school before my 4 years of medical school, right? Then you have to do a residency in internal medicine, 3 years. Then you have to do a fellowship in kidney disease. I did 2 of those. I did research for 2 years, and then I did a clinical fellowship where I was working in the hospitals and all that for 2 years. So you got to get a lot of school under your belt before you can even sit for the test to become a nephrologist, right? But the answer to your last question, you just got to tough it out. The treatment's not going to be, I'll put it to you this way, the system wasn't designed for me to be there. Oh, right. There's lots of money involved in school these days, in that particular school, because they don't give scholarships for that. Please, this is Renee Beiser. She is the director of Vermont Village, who helped and hosted this for us. So I'm gonna give her the floor for sure. Thank you.
Well, good afternoon. Thank you all for coming. This is one of many seminars and classes that we will be hosting. We're trying to get to a point where we open a wellness center for the community to continue to disseminate information. So look forward to more radio announcements. We'll be doing some entrepreneurship training, some A1 boot camp training, first time home buyer training, you name it, and we'll have a workforce center. To tell you about our workforce center, it is so phenomenal. If you are in a career and decide you want to change your career, it will tell you all of the classes that you need to take. It will also calculate and tell you what questions that you should ask in an interview and prepare you. And then it has sound where it will monitor your voice while you're taking an interview.
Wow.
And if they think that you're not confident, our coaches will come back to you and tell you need to grow in a particular area. But we have a 30% increase in job security after people are going through the program. So look forward to those announcements. So on Saturday, April 5th, the Red Cross, I have on my FEMA badge as well. I'm badged with FEMA. We will be canvassing the area to have smoke detectors installed in people's homes. And so we're asking for each of you to please, as you come out today, become partners of Vermont Village and Crenshaw Christian Center to help us disseminate the information to our community. Having worked a disaster, there is nothing like waiting until the last minute to try and get prepared.
That's right.
So it only takes 30 minutes to install the smoke detectors. So if you would all come out and please help us to get the word out to our communities. We will at some point have disaster preparedness here on campus. I've talked to the CEO about doing that. So just to share with you, I was called all the way from California to go to Texas to improve the economic environment for Houston when they had the disaster, Hurricane Harvey. And so just to share with you, water moccasins coming out, fires starting,
That's right.
gas lines, wearing snake boots. I've crawled through freeway paths, unusual bugs, things of that nature. So we're starting at a very, very low level. A smoke detector could save someone's life. Please come out. And then twice a month, we also do blood drives here on campus. And so look for those announcements that are coming, but please come out and help us. There are flyers in the back of the room, and there's QR codes on the back of the flyer. And once you pick up the QR code, it will tell you the place and time here at the Crenshaw Christian Center, and you will be assigned teams where we can go out and canvass the area to help our community. We want to build our community and give equal access to everyone. So thank you again for coming, appreciate you. Great questions, great audience. Tell a friend next time. Yes. Because we are here to stay and to grow wealth. That's right. And to grow our health.
That's right. That's
Thank
right.
you.
So I guess we're going to go on and wrap it up if there are no more questions. Oh, one more question here.
How much water should we be drinking a day? And the list of antioxidants, how much we should be eating a day?
Well, those antioxidants are in the form of nuts and berries. So with nuts, I usually say about 3 handfuls of nuts per day. Okay? Any kind on there. Just a handful. Because nuts also have cholesterol in varying amounts, and you don't want to overdo that with your nuts. But the antioxidants, so three handfuls of that. The fruit, knock yourself out unless you're diabetic, watch it. But fruit, knock yourself out. Water is based on your size, okay? So water is based on your size. Usually it equals to about half of your body weight that you should drink in ounces. About half. It's a little more than that, but if you remember half of your body weight in ounces, that's what you should be drinking, roughly, of fluid. Not just water, but fluid, stuff that actually replenishes. Because water sometimes, particularly the bottled water, it runs right through us because it has no minerals in it, or very few minerals in it. The mineral water stays in your system more. It really hydrates you more. Okay? All right. So without further ado, we're going to wrap up. But I really would like to thank Renee Beiser from Vermont Village, West Athens Westmont Task Force for having me out. This is one of a series of these that we're doing. So we're going to be doing one a month, at least for the next 2 months. And then after that, we're trying to keep this going for as long as we can, because we feel it's vital as a group to do. Okay? So thank you for coming, everybody. We'll see you next time.
Hi, my name is Linda Anderson, and I am a member of the West Athens Westmont Task Force, and I came today to support this educational event that was being done by Dr. Vincent Anthony. The whole idea about kidney care in our community is so important, and I have to tell you that the information that was shared today, everybody in our community needs to know about, because each of us knows someone who's going through this kidney battle, and it's not fun. So just the opportunity for the task force, Dr. Anthony, and all the other that contributed to this Vermont Village. It was just a great afternoon. So we hope that you'll have an opportunity to come and join us at our next one. Thank you.
Hello, my name is Beverly. I came to the health and wellness conversation with Dr. Anthony to be more informed. I have family members who have had health issues with kidneys, and just want to be more proactive in my own health, family health, and share with the community so that we can reduce the numbers and live longer. But thank you for the Crenshaw Village and Crenshaw Christian Center for hosting the event, West Athens, Westmont Task Force for spearheading it, as well as 2nd District Supervisor Holly Mitchell for sponsoring the event. Everyone should come out to the next one on April 19th at Irving Magic Johnson Park from 11 to 1 as well, to continue the conversation with kidney health, just health in general, with sugar diabetes, blood pressure, and just being more informed so that we can live longer and be healthier.